thank you all for being here tonight, joining us for LaSalle College Presidential Speaker Series. Tonight is the first event in our spring series featuring presentations about important issues related to the upcoming presidential election. So tonight, we'll be focusing on healthcare, specifically the Affordable Care Act of 2010, also known as Obamacare, how it's working, and what might happen to it after the election. It is my pleasure to introduce to you Dr. Nancy Koehn, who, in addition to her role as the Associate Dean for Case-Based Teaching and Learning at the Harvard School of Public Health, is also an Auburndale resident and a LaSalle College neighbor. Dr. Koehn is an author, lecturer, and recognized expert in managed healthcare and has received numerous accolades for both her research and expertise in teaching. She also consults with a wide range of federal and state agencies involved in health system design, oversight, and payment, including serving 2 terms on the Medicare Payment Advisory Commission, advising Congress on issues affecting Medicare program, and she also served as a member of the Massachusetts Special Commission on Healthcare Cost Containment in 2009. Please join me in welcoming Dr. Nancy Koehn.
Thank you. It's great to see you. I thought I would try to, I'm not going to cover the whole Affordable Care Act or what's in it, because frankly, there's not enough time in the evening, and if you've had a glass of wine, you'll probably go to sleep if I do that. But I thought I'd add a little drama to the talk just by having the thunderclouds up here that have been tormenting the Affordable Care Act since it was passed in 2010. And just to give us a little more drama, we've been trying to pass an act that gives universal coverage since Teddy Roosevelt, 1909, somewhere in there. It was 6 times before the Obamacare legislation we have been trying to get universal coverage. And so, yes, it's not perfect, but it is an amazing feat considering that it's taken us 110 years to get it through our legislative process, and always for different reasons. So Teddy Roosevelt, FDR, Harry Truman, LBJ, Richard Nixon, and Bill Clinton. So fairly bipartisan in terms of the different presidents who've tried to lead the reform. Finally, you know, Obama did get this through. I actually call it Reagan Care myself, because it modeled on what we passed in Massachusetts in 2006. So I think if we can just try to strip away the political rhetoric and understand what it is first, you know, fixing it, whatever, changing it, we can go from there, but it is an amazing accomplishment despite the House trying to repeal it or defund it, or 50 times since 2010. Supreme Court has been engaged 2 or 3 times in different challenges to whether or not, first of all, whether the individual mandate was constitutional, or whether the feds can make the states do things with the Medicare program, or whether the feds are not allowed to fund the individuals. I mean, there's just been it just sounds like a nightmare of implementation. I will say, and I suspect some of you here, I just got my Medicare card today, by the way. Medicare, when it was first passed in 1965, went through a very similar set of challenges. And almost, really was just a constant battle, and is still being tweaked today. Yeah. So, yeah, in terms of payment, in terms of eligibility, in terms of what kinds of services they will cover. So it is hard to have a public insurance program in any country, but ours in particular, because we're just so opinionated about we don't have that sense of solidarity that often is behind what makes these things work in Europe and other countries. And then, of course, the governors of all 50 states have a major role in big chunks of how this law gets implemented. So what we observe in Massachusetts, we actually already had it before 2010. But if you go to Texas, man, there's nothing happening down there. And there's a lot of states where I have a place in Maine where one of the poorest states in the nation, I might add, where they have refused to expand Medicaid and don't want to accept federal money to take care of their low-income people. So we'll kind of take a trip through what's important about the act, and then we'll hopefully have plenty of time for questions. Okay, let's see if okay, so there's 10 titles to the Affordable Care Act. The 10th title was actually because the House had to pass the Senate version because Scott Brown got elected to the Senate, and so they didn't dare let that act go back through Congress once we lost control of the Senate. So the 10th title is actually the manager's amendments trying to create some kind of, normally when a bill is passed, there is a reconciliation between the House and the Senate bills, and they argue about it and fight about it. Well, they didn't dare do that. So the House just passed it. Under Nancy Pelosi, when she was still Speaker, they were able to sort of jam it through, but it's a mess. I mean, it's a huge 1,000-page mess. And Title 10 is a bunch of amendments to all the other 9 titles. The first, Title 1, is the affordable, making coverage affordable and available. So it relates a lot to governing the private insurance industry. So they're not allowed anymore to discriminate on the basis of your health history. They have to allow anybody who wants to sign up. Their packages have to be more transparent. They have, a lot of insurance regulation. But to get the insurers to go along with that and make it work, you have to get the healthy to pay for the sick. So that's the individual mandate. As soon as you lose the individual mandate, you can't require the insurance companies to take all comers because people will just sign up when they're pregnant and then get off when they're not. So, and that's, I love people, but they do these things. So the insurance part is the affordable and available coverage. And also setting up these marketplace exchanges, that's all part of Title I, which you'll hear a lot about. And it's also, the exchanges were meant to be the place where the consumer can go, the individual can go and shop online and compare prices and benefits across a fairly standard template so they could understand it. I don't know if any of you ever tried to shop for private insurance as an individual in the past. It was impossible. Yeah, you really can't. I mean, most of us have group insurance where our employer did it for us. But if you went out there and tried to do it yourself before the Affordable Care Act, you would have just gotten lost and gone immediately to a broker and said, can you just help me figure out how to get something the lowest possible cost for me. So the exchanges play an important role in creating a marketplace that's transparent and understandable for individuals who want to buy health insurance and not have it through their employer, and also for small employers who want to offer insurance through the exchange. Title II is the Medicaid and CHIP, or the Children's Health Insurance Plan. Basically, until Obamacare passed, you only got on Medicaid if you were both low income and categorically eligible. Now, some states took exception to that and expanded it at their own expense, but you had to be basically a parent of a child to be categorically eligible, or disabled and elderly. So what the Title II does is expands Medicaid to people who are adult, don't have children, but are just poor. Before Affordable Care, and continuing on in the states that didn't go along with it, how many knows, well, you probably don't know. In Texas, if you're a parent of a child, therefore categorically eligible for Medicaid, if your income exceeds 19% of the federal poverty level, 19%, you're not eligible. Okay, so 100% of federal poverty is still pretty low, but if it's 19%, you are not eligible, and that's still true in Texas because they didn't expand their coverage. So even if you are categorically eligible in Texas, you really can't have any money. So that expansion was meant to, and I'll show you more about that, was meant to make more people have it more based on income than whether you're a parent or disabled, and also to raise the income eligibility limits, and I'll show you what that is in a minute.
Some people in the back are having a hard time hearing you,
okay.
So I wonder if you might use the microphone. Is that?
I can, except that I can't see what I'm doing if I do that. So, it's really related to what you hear about a lot in the newspaper about accountable care organizations, patient-centered medical homes, and everybody should have a primary care physician, and that the provider system should be accountable for the health of a given population. And that's, a lot of that work actually came from the Medicare work, in fact, the stuff we did when I was on MedPAC, trying to change the way providers are rewarded. Because up until 2010, and still now, the predominant method of paying a provider is you get more if they're sick in fee-for-service. The sicker you are, the better your provider does. And the notion behind delivery system reform is to say, no, you should be paid to keep people healthy. And that's a complete transformation of mindset, culture, payment systems, and even how they organize care. And so the words the buzzwords you hear around that are accountable care organizations, which are large groups of providers that will say, I'm responsible for the entire population of LaSalle Village. And you'll pay me a capitation or per member per month, and it'll be a better payment if everybody stays healthy and a worse payment if everybody gets the flu in a year where they should have had vaccines. That kind of thing. So that's what the accountable care, that's what the idea is. Now, it sounds simple, but it is, believe me, so not simple. But I'll show you some of the things that have been happening in that. And then the Medicare reform is really basically saying we're going to take a lot of money out of Medicare to help pay for this bill. And that's the talk I give in Florida. And there's a lot of interest in it. But it's things like paying the doctors in the hospitals a little less than they otherwise would have gotten. It's reducing the payments to what they call the Medicare Advantage or the Medicare HMO plans. Oh, yeah. Those kinds of things. You'll read about them, a lot of complaints, but actually it was the right thing to do. It's just not easy to do. Reducing the amount of money that goes to the safety net providers, because theoretically Medicare had always paid them a little more because they take care of poor people who are uninsured. But the notion is if we're insuring everybody, they shouldn't need so much money, so we're going to reduce it. No. None of this stuff works perfectly, but that's the idea. So those are the things that Medicare, and then of course increasing, means testing the premiums on Part B, which some of you have probably noticed. Yeah, it's getting to be pretty tough for people who have, well, I mean, the good news is you have the money to be considered high income. The bad news is the actuarial value of your Part B premium, you're paying 85% of it if you're wealthy enough. So they're getting seniors to pay more based on their income for their Part B care. And then there's other titles. Prevention and wellness, for instance, now any preventive service is supposed to be free. You know, your physicals, your screenings, the types of things that keep people healthy are now, for both Medicare and private insurance, those are pretty much free. You don't pay a deductible or a copay on those. Wellness. Workforce initiatives include mostly helping the community health centers get better access to workforce, and on and on. Fraud and abuse, pathways, biological similars. That sounds terrible, doesn't it? But I'll just give you a little bit of a sense of what that means. A lot, in the last 15 years, we've had an explosion of drugs that are based on biological change, biological development, as opposed to chemical development. And those biologicals are really hard to replicate, to create a generic out of, because it's a process rather than a compound, a chemical compound. And so the brand biologics costs are off the charts. A lot of them are used in chemotherapies. And as those of you who are on Medicare know, many of you are paying 20–25% copays for those drugs. And if you're paying 25% of a $20,000 a month drug, you go broke pretty fast. And there's no limit on Medicare, no out-of-pocket limit. So this pathway for biological similars is trying to get the equivalent of generics into the pharmaceutical industry for these types of biologic products. And it's a rough road. They're still riding that one. CLAFS got repealed, so we won't go there. And then these various revenue measures is the Title IX, which is a tax on employers who don't offer health insurance if they have a certain group size. The individual mandate, if you don't get individual coverage, there's a tax. Things like that. So that's the title. That's the act as it passed in 2010. You probably can't see that.
No.
So I'm just going to show you the important parts if this little blinker works. No, it doesn't. So let me just say, how do you think, so this thing's going to cost us, let's just say, $1 trillion. The way we're funding it, so the Medicaid expansion is about half that, and the private subsidies for low-income people who are not eligible for those subsidies is the other half of that trillion. How are we going to finance it? Half of it comes from Medicare, those things I was telling you about, and then about half comes from those revenue measures of Cadillac tax, if you've heard about that, individual mandate penalties, those kinds of things. So Medicare is paying for half of this. And it was kind of, when I saw them doing that, it blew my mind because I'd been on MedPAC from 2005 to 2011, the Medicare Payment Advisory Commission. We had spent almost that whole time until 2010 thinking of ways to make Medicare financially viable for the next 50 years. And every one of our ideas got put into the act to use to support Affordable Care Act, as opposed to keeping Medicare financially viable. It's magic the way Congress uses funds twice. Anyway.
Very imaginative.
Very imaginative, yes. So I won't go into, that's basically what that slide says, is we're paying, you know, it's meant to pay, the $1 trillion comes out of basically Medicare and these revenue sources. So let's talk about Titles 1 and 2 a little bit more so that you have some idea what those are about, expanding, basically around expanding insurance. And the idea was that you'll see that Title II is the Medicaid expansion, which allows people up to 133% of federal poverty level to be eligible for Medicaid without fitting any other category, like, you know, a single mom with a kid or disabled. So an 133% of federal poverty level, as I mentioned before, is quite a bit higher than many states have allowed to date. So as soon as states say, okay, we'll let you into Medicaid at 133, you're letting in a lot more people than when it was down to 20% of federal poverty or even 100% of federal poverty level. Now, one of the sensitive political issues around Medicaid expansion is it's a federal state program, and the states pay a chunk of that. Now, the Affordable Care Act says, don't worry, we know you're going to have a lot more people, and the state's going to have to pay some of that, but it'll only be 10% for a while. And then then we're going to try to make it back more like the 40-60 that it has been traditionally. And that's scary for a lot of states, and especially states that don't believe in this to begin with. And even if you look at Massachusetts, which again started this in 2006, you can see the cost of the Medicaid expansion has squeezed out growth in every other line item in the state budget, including education, highways, aid to communities, mental health, all those things. So it is a big price tag. Just the tiny bit that's the state portion is not so tiny when you have that many people coming in. The blue is people get eligible between 134% of federal poverty and 400%. They can get subsidies for private insurance on the exchanges. They can't get those subsidies any other way. You have to get it through the exchanges. And that's why these exchanges are so important to have set up and running well. And we'll talk more about that in a minute. And then if you have income over 400% of federal poverty, you're not eligible for subsidies or Medicaid, but you can shop on the exchanges for these products that are much clearer and more transparent than products have been to date. A lot of people squawked about how their private insurance, especially the individual coverage stuff, was they had to give it up because it didn't meet the minimum standards of a federal product. It turned out about 600,000 people did have to upgrade their coverage to meet the federal standards. But there are, I think, something like 7 million people who have individual coverage, so it's not a huge number of people, relatively speaking. But they can make a lot of noise in the media. So one of the big things is, and the Supreme Court was asked, that first of all, the individual mandate was challenged, as you may recall, back in 2012. And the proponents wanted to call it unconstitutional. But unfortunately, the Supreme Court in a very tight decision, decided it was indeed constitutional, but what wasn't constitutional was for the federal government to make the states expand Medicaid. It had to be voluntary. So, as of today, we have 32 states, including District of Columbia, that have gone to the 133%, no categories. We've expanded Medicaid in 32 states. Another 3 states are still talking about it, and 16 states have not expanded their Medicaid eligibility, which means that in Texas, for instance, which is not expanded, you still, if you make over 19% of the federal poverty level, you still are not eligible for Medicaid. And if I go back to the slide that says you're eligible for subsidies if you have between 134 and 400%. Well, what happens if you only have 100%? Your income's at 100% of federal poverty level and you live in Texas. So you're not eligible for Medicaid and you're not eligible for a subsidy because your income's too low. That's called the coverage gap. And it's bad news if you're in it. And so for 16 states, including Maine. Now, this has always boggled my mind why people would turn down federal money. I know, it will cost the state something, but how do you think they take care of uninsured people now? Who pays?
They don't.
Well, some of them they don't, but they often do. And the way they pay, this is where a lot of my research is, the way most states, like Texas, like Florida, who haven't expanded, the way they pay for them is they tax local property and sales. And they fund public hospitals. And a lot of these non-expansion states are charging their local residents a ton of money so that they can say no to federal tax dollars.
That's the emergency room culture.
Well, it's just like, what are they? Yeah, they are cutting off their noses, and some of them are beginning to realize it. And
Are they?
yeah, oh yeah, even Rick Scott in Florida. So, ooh, I actually think Rick Scott, who actually used to run a healthcare company, so he knows this stuff. The governor of Florida finally said, I think we should expand Medicaid coverage, and the legislature said no. It's overreaching by the federal government. So, whatever. So it's it's kind of crazy. And I think over time, Medicaid had the same problem back in '65 when it was passed, the Insurance for the Poor. It did not get implemented in every state, I think, until like 1980. I think Arkansas might have been the way. I can't remember which one, but one of those states out there in the west of the Mississippi. So what you can see, we have a very uneven implementation of the Medicaid executive, and feel free to keep speaking up if you can't hear me, of the Medicaid expansions. The other place that the states could make a decision was whether they were going to run their own exchange or marketplace or have the feds do it for them. And it turns out that's also very mixed. 27 states said the feds are going to do it. I'm not doing this. And they're the same states, pretty close, that don't like Medicaid expansions, but some of them do have it. And then only 16 ran it on their own, and another 7 are sort of a joint venture with the feds. It turns out that if the state runs the exchange, they are much better at signing up people. So if the states run the exchange, in the very first year when they, in 2014, they were able to sign up something like 80% of the target market of uninsured people, whereas the federally run ones signed up like 50%. So we do know that when the states run it, they run it better. They're more into outreach. They put their effort behind signing people up. Whereas if the feds are running it, it's harder to get the population to go on the exchange and buy their products. And the states have a lot of control over how those exchanges define the products and regulate them. So there's a big difference between a federal and a state exchange. The expansion started in 2014, except for the one about people between 19 and 26 who, as soon as most health plans, commercial health plans say when your kid is 19, unless they are in college, they're no longer under your family coverage. And that was a big source of the uninsured. And one of the first things Obamacare did in 2010 was say, if you are between 19 and 26, you can stay in the family plan. And that was huge. So they're already in these numbers. And what this, I'll just sort of talk you through it because you can't see it. So the top line is, the purple line is the growth in the employer-sponsored health insurance, not subsidized, not Medicaid, just employers, people buying more insurance through their employer. And that already has those 19 to 26-year-olds in there, because this is 2013, it's 2 years after they started joining. And what you see in the first line is in September of 2013, so it's before coverage begins. And the first set of coverage started in about four dots down there on the x-axis, the January of 2014. You see employer-sponsored coverage enrollment shoot up. Despite all the claims that, oh, employers are going to drop coverage and send all their workers to exchanges and work on it. They didn't do that. They actually stepped up. And then you see Medicaid, which is the red line, starts to really shoot up because of all these expanded people who have low income. And then the marketplace, which is the lowest line, I'm going to show you another slide that shows you that too. But people on the exchange start picking up. It goes from 0 to about 12 million. So you start to see these different ways of getting coverage shooting up over time. And this is just 13-14 when they first allowed people to get covered through the terms of the Affordable Care Act. And this is, maybe you can see this better, but this just summarizes what that slide says in numbers. Employer coverage went from about 112 million in 2013 before all the eligibility kicked in to 120 million by 2015. So big jump, 10 million people, 8 million people, sorry, joined employer-based coverage where there's no subsidy at all. Medicaid jumped up by 10 million, which is what you'd expect. The individuals, people buying on the market, on the non-group market, not in the exchanges, went down because they went to the exchanges instead because it was a better deal for them mostly. And the marketplace went from 0 to 11 million people. And then a lot of the, what used to be local county indigent programs, they got dropped, and those people went into Medicaid. So a much better deal for the local taxpayer. So in total, we added $17 million. People, excuse me, 17 million people. Hello, dollars, people, what that? 17 million people were added to the insureds in the first year of enrollment.
The employer one could have gone up because also there were more job opportunities that came out in the last year, right? Or
it's actually, the same thing happened in Massachusetts, though. I mean, and that was in 2006. In other words, employers, there was a penalty. You do pay a tax if you're an employer, you don't offer insurance, but it's a tiny, it wasn't a big one. But I think a lot of employers, they want to insure their employees, and the Affordable Care Act gave them ways to do it that was a little cheaper. Well, we'll come to that. That's one of the problems with the whole thing, how they got them cheaper. So anyway, in the first year, getting up to 2015, the first 2 years where people sign up, we've insured 17 million people. And they expect that to continue to grow at a slow pace. The big growth was the last 2 years. So yeah, there were 42 million uninsured before, and now there's 26 million. So that we have insured net. This is just there's about 15 million people, young adults, 19 to 26. They are already in that early, they were in the first 2013 numbers, but half of them would not have had coverage if they hadn't been for the Obama Act, because they would have been not in school and over or between ages 23 and 26, where you weren't in school anyway and you had to get health insurance. So it's been a lot more people. So if you add those people with the other 7 million that have been gotten coverage because they're young and they're on their family plan, at 7 million plus 17 million, you're getting up there into the 24 million people have insurance that would otherwise not have it if it weren't for the Affordable Care Act. Now there are still a lot of people who aren't insured. 32 million people are not insured still, and it'll be hard to get them, but half of them, you can see on the right side of that circle, half of them are eligible for financial assistance, either through Medicaid, either as an adult or a child, or through a subsidy on the private insurance exchanges. So that I mentioned before that some of those exchanges have not done their job of going out and trying to recruit people. That's where most of those people are. They're in states that don't have a very active or well-run exchange. 10% are in that coverage gap that I mentioned, that if you don't make quite enough money to get a subsidy, but your state didn't expand Medicaid, you can't get coverage. These are. And then some are ineligible because they're not citizens. We still, that's a big issue. No illegal immigrants are allowed in. And some aren't eligible because their employer offered them health insurance and they turned it down. And if the employer offers health insurance, you can't get on the exchange for a subsidy. And then some are just make a lot of money and they just don't feel like buying insurance. And I always love it when people say, well, I'm just going to keep myself healthy this year. Good luck. Good luck. Yeah. But there is that mindset out there that you don't need it. And I think the whole notion and this is where I think the Obamacare people who talk about it, try to communicate it, never really clarified. I mean, I would call those people who could buy it but don't want to, I would call them freeloaders. Because if they hit the health system, they're going to get care, and the rest of us are going to pay for it. But somehow freeloader never got cut into the the communication of who are these people who are live free or die people. But unfortunately, they do live, and I pay. But anyway, I'll stop venting on them. But it's just been I think a communication error on the part of the administration to not make that sort of try to make the people who don't join who could be viewed more negatively than they are. I know the libertarians think it's fine. How's my time here? Okay, good. So now I'll talk a little bit about Title III, which is the effort to reform the delivery system to make healthcare more affordable, higher quality, you'll hear the word value. They usually mean by value, lower cost, better quality, better access. So, yeah, no problem. And that's the stuff I've been working on for 35 years. So, if they can get that to work, I'll just be so impressed. And so one of the ways I mentioned is to develop accountable care organizations. So instead of going to your doctor who then refers you to your hospital and maybe one of possibly three, you're going to go to your system. And your primary care doctor is one component of that system. And they're all accountable for your care in both a financial way and in a transparency, like your system should be able to show on their website how good they are at taking care of your problem. And in fact, in Massachusetts, I think your insurer has to tell you how much you'll pay out of pocket if you go to Beth Israel's, endoscopy unit versus the Brigham's versus Boston Medical Centers. So transparency on both cost and quality are part of this effort to create, when they use the word accountable, that's what they mean. They're accountable for the quality and the value of care. And what you see nationwide is, since 2011, we've gone from 64 accountable care organizations to over 700. Now, there's a downside to that because what that means is we're creating even bigger monopolies that have great power to negotiate prices, and that's something we're working on in Massachusetts and nationally. It's actually happening everywhere. But you'll often see in the Globe the concern about market power and price disparities, and it's real, and it's a big problem. But these accountable care organizations, so it's sort of a tension. We want to have organizations that will take responsibility for the health of the population. To do that, they have to be at least under some kind of common control, and that means healthcare organizations get into bigger and bigger entities to do that. And the bigger they are, the more they can negotiate, tell prices.
If the PC is kind of a gatekeeper, or PCP,
Pensions, yeah.
Then can the unit that the PCP pot increase the PCP's income because they're saving money by shifting?
It all depends on how they pay the PCP.
Yes, that's what I thought.
And I think it's borders on unethical to put a PCP on a full risk contract. A very large group like Atrius, that's okay because it's a very large group, but it's actuarially unsound on a doctor with 500 patients or 2,000. So that's all being done in 1,000 ways.
1,000 ways. We don't know yet how when the accountable care organization gets paid by the employers and the insurers, we don't know how they distribute that money inside. And that's your question, and we don't know. Yes, sorry. So, but there are, more and more, everybody expects this to be the predominant way we will be getting our coverage is through your doctor being connected to an accountable care organization, and that care organization paying them somehow to be in line with the goals of the ACO. And we see now, I think this is the number of contracts, both government and commercial are doing ACO. It's not just Medicare ACO. It's in Massachusetts, I would say the private sector commercial ACOs there's more of those than there are of the Medicare ACOs. So it's everybody. And what we do see nationwide is that the rate of growth in healthcare costs has come down.
The rate.
Yeah, the rate of growth. I didn't say it's decreased. It's the rate of growth. It is, but it is that red line over time. This is something like 1961 on the left end and 2013 on the right end. And you see the red line is the real trend. Now, whether it's accountable care or just exhaustion, I don't know, but it's definitely coming down. Probably a mix of everything. Why is it coming down? The economy drove it down a lot in the mid-'80s, mid-2000s, but it's still coming down. Now, there is another reason it might be coming down, and you can't see this slide either, so I mentioned that to make healthcare premiums affordable, they've had to kind of play with the benefit design, and what they've really done is increase the amount that you pay out of pocket. So the deductibles are going crazy, and the average deductible on those subsidized coverages and some of the low income individual coverages are $2,500 to $5,000 before you get a penny out of the plan.
Get out. 5K?
Yeah. Oh, 5K, yeah. Up in Maine, where we've been, 10K. So you'll be playing golf up there in Maine with some poor old, sea captain or lobsterman or something, and he'll say, I don't know why I have to buy this health insurance. I just pay premiums and I can't use the insurance because I don't, to meet that deductible, I can't afford it. And they really can't. So that is why a lot of people are having trouble paying for their health care, is they're not covered for the first $5,000. Yeah, I mean, one thing the Affordable Care Act is, it say, for individuals with a certain income, you can't have a bigger deductible than $2,500 or $5,000, but it's still a lot of money for low-income people. So that's one way we've kept it affordable, and it does affect care because that upper yellow line basically says it's the percent of people who claim to have foregone care because of cost, and it's gone up. More and more people are. Now that might be a good thing. We don't know whether that care was important or, cosmetic. And there's been a lot of experiments about that. Many people say, oh, when you have skin in the game, like you have a $2,000 deductible, you're only going to go for needed care, but that's not always true. And the more low income you are, the less likely that is true. So that's, again, some of the pieces that if you could rewrite this legislation and change the way the deductibles and the out-of-pocket limits are set up, you would. But again, we can't run this through Congress. It's not now. No, never. Well, now let's talk about the future. I don't have a lot to say about the future because that's one of the problems about the future. It's hard to know what's going to happen.
Legislative.
Yeah. And it's really hard in this particular race. So we've got Donald Trump, who actually for a while was saying he wanted a single payer system like England, Scotland, and I think another country, I don't know, Canada, I guess. And so he says, as far as single payer, well, then he just kind of waffles. I don't even know what he means when he says, as far as single payer and all, there's so many different things you could have, honestly, to do to have great health insurance.
They sound like them.
The one thing I do tell people is we're going to have something great. We're going to repeal and replace Obamacare, which is a total disaster. But the only thing I did a Google search of what is he saying he's going to replace it with. Right now, his big idea is encouraging competition across state lines for insurance. So you say, well, look, it's cheaper to be, you know, buying, if you live in New York, you're looking at a 25-year-old male, you're looking at a premium of $1,000 a month. If you live in Arizona and you're a 25-year-old male, you're looking at a premium of $25 a month. So the guy in New York should be able to buy the 20. No. I'm not sure how he's going to exercise it because it's probably a narrow network in Phoenix and he lives in New York. But hey, you know, it's complicated. And now, a much more serious candidate, Bernie Sanders, in terms of his health insurance ideas at least, single payer, which means basically Medicare for all. And I'll talk a little bit about that, and that might be something we should just sort of open up to your own thoughts. But he believes that if a state, you know, can pay, Vermont tried to pass single payer.
Yeah.
Unfortunately, they decided after a while it wasn't feasible, and it would cost too much to do. But they said if we can demonstrate that we should have it nationwide. And he is very much out there for single payer. Hillary Clinton is saying, what do we need to do to try to fix this, meaning Obamacare? Because it would be a great tragedy, in my opinion, to take away what has now been provided. This is going to be challenging, and I don't think we should throw the baby out with the bathwater. So she's basically defending Obamacare. We all acknowledge it needs some changes. Can't run those changes through Congress until the politics change dramatically. But as I said, it's taken us 100 years to get this. And so we really are sort of stuck. And that's the future. I mean, I haven't heard a Republican presidential contender say anything yet, except that they want to repeal Obamacare.
Be sure of that.
Yeah, so I haven't been able to say what the future might mean if they repeal it, except that we might be right back in the hole we were in before with 42 million uninsured people, but a whole lot of really upset providers who have been reorganizing and spending billions of dollars to try to, you know, become more efficient and be accountable for the care of populations. So yeah, so maybe I should. Oh, I also want to mention on single payer, because I always thought it would make, you know, if we can start from scratch, yeah, let's do single payer, but you know, we can't. But it's Medicare is a single payer in theory. You know, we're all in it after a certain age. But Medicare has, over the last 20 years, done anything it can to get people to sign up for private health insurance through the Medicare Advantage, through the HMOs. You know, because it tends to be a better deal ultimately to have a private insurer manage that care, sign those people up, customize the network, negotiate the contracts. I just got back from a trip to Louisville where I spent some time visiting Humana, which is a big vendor of Medicare Advantage managed care plans. And they're doing this, they've taken this population health idea to heart. They've got a giant database. They can profile you and figure out that, you know, your heart disease is because you're buying too much Chinese food, and, you know, and they're going to send a nurse in there to help you learn or cook, to show you better ways to cook.
If it works.
Yeah, well, the feds aren't going to do it. I mean, so this idea that Medicare is a great, it isn't really a single payer. It's actually delegating out to tens of, you know, hundreds of managed care plans.
What about the VA?
And the VA is, well, they're a single payer, although they also are able to contract with the private sector, but they are a single.
But how would that be as a model?
Oh, well, I don't know if you've been, yeah, so actually I'm a big admirer of the VA system until we got to the last 2 or 3 wars, Afghanistan, Iraq, and whatever went on the last couple of wars, because they were very good when they kind of had steady demand they could plan for, but when they started getting a whole lot of new and young people who weren't you know, sort of Vietnam era or World War II era vets who only about 50, I think they only served about 15% of the vet population. But they were predictable. This is unpredictable, very expensive, and they don't have all the full range of service, and Congress won't give them enough money to do it. So I teach a program with physician executives, quite a few of whom come from the VA. And they're really suffering because they cannot get the resources in to take care of, we send them to war, but we don't want to take care of them for life.
That's not a model problem, that's just a fight.
Well, but that's always the problem when you have a government, you know, say in Canada. I have students up in Canada, 11s. Same thing, Canada hit the wall during the recession, and they're taking 25% out of their healthcare budgets in each province. That's the vulnerability that you have. And I'm all for a single payer idea, but how do you finance it and make sure it's always adequate? Here, we've always had the safety valve of a private sector and of employers being the primary people who buy the insurance for us. So that's my opinion. Other people will obviously have disagree with me. So let me open it up to people's questions or